Good morning to all of you. Thanking Jayagopal sir and organizing team for the opportunity given. I believe this was sent for the for this conference by Dr. Anthony, and fortunately I got an opportunity to present this case. Thank you once again. Well, this was an elderly gentleman who had a bypass surgery in 2001. He had a Lima to LED vein graft to diagonal RC and OM. He had a check angiogram in 2014. Vein graft to OM was occluded. Now he presented with an infeval myocardial infarction in a nearby hospital. He was thrombolized with retiplase, did not have relief of symptoms, was referred to us for a rescue angioplasty. The left system was reasonable. The graft to the OM had occluded, but then the flow inside the OM was reasonably good. The LED was occluded in the mid segment. The right coronary was occluded in the proximal segment. In the second image, you could see that the right coronary is occluded. And those are the vein grafts. The vein graft to RC is proximally occluded. Those are the second one shows that the flow inside the diagonal branch is good, even though it's a very small graft to the diagonal. Well, the flow inside the Lima also was good. So our plan was to open up the vein graft to the right coronary artery. Normally, it's recommended that when you have a post-CABG infeval myocardial infarction or so, it's better to open up the native vessel rather than the vein graft. But then here the native vessel, the right coronary was austerely occluded. It was a chronic total occlusion. So we decided that we have a try our luck on the vein graft to the right coronary artery. That's a guide catheter, the multi-purpose guide catheter. Sitting well aligned in the vein graft to the right coronary artery. Wiring was extremely tough. We could not get the run-through wire across or Versitan wire across, so we wired with the Fielder XT wire. That's the Fielder XT wire. Then we started aspirating the graft. You could see that we aspirated a lot of clots from the proximal end of the graft, and still there is some amount of clots remaining there. We had to have almost 10 passes, more than 10 passes of aspiration from the proximal portion of the graft. You could see now that in the mid portion of the graft there is a tight stenosis. Still there is some amount of clots left, so we again took the aspiration catheter. In the second image you could see that we were pushing our multipurpose catheter across so that we could go distally and aspirate also. Because the multipurpose catheter was well aligned to the vessel, we could easily push it across without damaging the vessel. Then after that we had a tight lesion in the proximal mid portion of the vein graft. We dilated with a 2.5 millimeter balloon at just 8 atmospheres, hoping that it wouldn't embolize distally. So that was a balloon dilatation at very small pressures. That's the amount of clots that we could aspirate from this proximal graft of the right coronary artery. And once the balloon dilatation was done, you could see that the flow inside the vessel is good. There are two lesions, one in the mid segment, which is actually the culprit, and distally also there is another lesion. So we wanted to stent both the lesions. The challenge with this while stenting the mid lesion is it's going to embolize distally. We would end up with this slow flow. So we wanted to have a distal protection device for during stenting of the mid lesion, which is actually the culprit. So again, if you look at the distal vessel, there is significant amount of lesion there, which would prevent us from deploying a distal protection device distally. So we decided that we'll stent the distal lesion first. So through that proximal lesion, we could track a stent distally. The stent was deployed. It was a 3.5 millimeter stent. It was aggressively post dilated so that while positioning the distal protection device, it won't get stuck to the stent. So subsequently, we took the distal protection device distally. That's the distal protection device being launched into the distal vessel that is actually positioned inside the stented segment. You could see that the distal protection device going distally beyond the lesion, and once that was deployed, we were able to get the stent across in the proximal segment. That is a 4 millimeter stent, one proximally, then furthermore proximally there was a lesion that too was stented, and that's the stenting being done, 4 millimeter stent in the proximal segment. And finally, we had in this image, you could see that there is some amount of, first image you could see that there is some amount of slow flow. We removed the filter, and after removing the filter, we gave a lot of intercoronary vasodilators, and subsequently we were able to achieve good flow inside the vessel. So this particular case was presented primarily to highlight few points. One, usually when you have an MI with the vein graft, usually the outcomes are not good because it's huge amount of thrombus burden inside the vessel. Point number one. Here we had a CT of the right coronary artery. We decided that we'll try a luck with the vein graft. It paid off. Second point was to highlight the usefulness of multipurpose catheter, which is well aligned to the vein graft to the right coronary artery. Third point is to highlight the usefulness of distal protection device, stent the distal segment and then have the distal protection device. And finally, regarding the usefulness of aspiration catheter, we had multiple passes to remove the entire clots from the coronary artery, and finally we could achieve good flow inside the vessel. Thank you so much.